From Diamond Pharmacy Services, this is PodcastRx, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. On this episode, Chris Bender, clinical pharmacist with Diamond's optics team, gives us a rundown on the latest oral therapies for COVID-19 patients, paxlovid and molnupiravir. We look at how these therapies work, how they compare to existing COVID therapies like monoclonal antibodies, and what side effects and safety considerations they carry. And we also talk with Chris about the overall accessibility of these medications and how he's seeing them utilized in corrections and long-term care. I'm Adam Campbell. Welcome to PodcastRx. Over the past 2 years, we've heard so much in press reports, on social media, and perhaps at the family dinner table about the effectiveness of unproven or unauthorized oral therapies for COVID-19. Think ivermectin and hydroxychloroquine, for example. And while we're not going to rehash those controversies on this podcast, the desire for anyone who's sick with COVID to have a simple oral therapy for treatment is not an unreasonable one. Now, to be clear, the main pharmaceutical ammo overall to fight COVID-19 is vaccination, full stop. And while infusion therapies like monoclonal antibodies and Remdezavir have been available to treat select patients, you can't help but think, hey, if I got sick with COVID, wouldn't it be nice if I could just take a pill for it in the comfort of my own home? Well, in December 2021, the FDA granted emergency use authorization for not one, but 2 oral antivirals to treat mild to moderate COVID-19 in high-risk patients, paxlovid and molnupiravir. To help us better understand these new therapies is Chris Bender, a clinical pharmacist with Diamond's Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. Optics, of course, was profiled extensively in the last 2 episodes of this show, and a shameless plug here. I hope you can go back and listen to those if you haven't already. Chris is a good friend of the show and a frequent guest. Chris, thank you once again for joining us. It's like your 100th time on here, and I really think you're due for an executive producer's credit.
Well, we're certainly getting close on that, Adam, but I'm always happy to be here, and I really appreciate you inviting me back to always talk about interesting discussions.
Yeah, the door is always open. So let's just jump right into this discussion. I want to ask, really, how big of a breakthrough are these new oral therapies for COVID-19? At first glance, it seems, this is going to be a big deal. What can you tell us?
Well, I should start by saying that anytime, a new treatment comes to market, that's really a good thing. Obviously, considering our current supply constraints, we really need as many options in our treatment armamentarium as we can possibly get. Now, with that said, these oral therapies in particular are a huge development. And that's really because, with oral therapies, you have the ability to reach a more broad patient population. So the previously available therapies, the monoclonal antibodies, they're only available as an infusion. And while that's fine for most patients, it does eliminate some of those who either have a significant fear of needles or those who simply can't or don't have the ability to make it out to a hospital, a clinic, infusion center, or what have you. So with these oral therapies, providers essentially now have the ability to send an order to the patient's local or, somewhat in their local area pharmacy, and they can receive that treatment in their own home. So obviously this adds a level of convenience for the patients, but it also has the potential to limit the exposure of healthcare personnel to these infected patients. And most notably would be those who are on the front lines administering the monoclonal antibodies to these patients.
In other words, a win-win.
Exactly, yeah.
Yeah. I just have to jump back to something you said, options in our treatment armamentarium. And I got to say, just props for using that word. It's not something you hear thrown around in podcast conversation, let it go in everyday conversation. So anyway, just a little digression there. But going back to the heart of the discussion, just for context, the current monoclonal antibody treatments that are out there, it's sotrovimab and bebtelovimab. And those are both under emergency use authorization, just like these new oral antivirals, correct?
Correct.
In addition to those monoclonal antibodies, Chris, there are still other infusion treatments, notably Remdezavir. That's an antiviral drug like the oral therapies that we're talking about now. And that's the only treatment out of everything with full FDA approval, right?
Yeah, correct. They actually, the FDA just, they obviously had the FDA approval for inpatient or hospitalized patients treatment, but it also too has FDA approval for non-hospitalized COVID treatment as well.
Okay. So, of course, the promise of these new oral therapies is that you don't have to go in a hospital setting to use them. So, the next important thing to ask is, how exactly do they work?
Sure. So, to put it at its most basic, we know that viruses must replicate to survive. And both of these new medications, they basically inhibit the virus's ability to replicate. Now, these two medications, paxlovid and molnupiravir, they do so in slightly different ways. So let's get into that a little bit. So the first is Pfizer's paxlovid, and it's actually a combination of two individual medications, nirmatrelvir and ritonavir. Now, ritonavir has actually been on the market for quite some time. It's commonly used in the treatment of HIV. But both drugs, both nirmatrelvir and ritonavir, are considered to be protease inhibitors. And protease is basically just a tool that the virus uses to cut larger proteins into more functional, more usable pieces. So essentially, viruses need this protease in order to continue replicating, growing, and functioning. So by stopping the protease, we stop the virus's ability to continue replicating. Something that's important to note about Paxlovid, because it's going to inform some of our discussion later, is that the nirmatrelvir component is really the one doing the heavy lifting in this combination. Ritonavir was essentially included in this combination mainly because of its ability to slow the metabolism of certain drugs in the body. So by giving the two together, ritonavir actually helps nirmatrelvir work better, which is kind of a classic Batman and Robin or Jordan and Pippin type scenario.
Nice.
Now, the other authorized drug, Monoperovir, which is made by Merck, it works by kind of confusing the virus during its replication cycle. So Monoperovir, or rather its metabolite once it's in the body, it's so similar to existing building blocks within the virus that the virus actually grabs the metabolite and incorporates it into its own RNA during replication. So it induces its own mutations. When it does this, the virus is not able to replicate properly. So Monoperovir, in a way, is a literal wrench in the gears of the virus.
How do they differ from the therapies that we've seen already?
Well, as I've kind of briefly mentioned already, they really differ in two key ways. One, in their administration, and two, in how they work. So in terms of their administration, the difference is obvious. The monoclonal antibodies require either intravenous or subcutaneous infusion in a healthcare setting, whereas these agents, Paxlovid and molnupiravir, can be given orally at home. Now, with regard to how they work, as I said before, these oral agents work from the inside out, meaning they enter the virus and they stop the replication, the viral replication from within. The monoclonal antibodies, on the other hand, they kind of work from the outside in, meaning they attach to the outside of the virus and they actually act as a signal to other cells in the immune system, as a signal to come attack and destroy the virus. So they kind of have opposite methods of working.
I'm so glad you went through each of those and explained, just on a granular level how they work. Molnupiravir almost sounds like a Trojan horse of sorts when it's stopping the COVID virus. It's really fascinating.
Yeah.
Now, Now, with these two new oral therapies, what of their overall efficacy? What's the data shown? Excuse me. What's the data shown so far on that? And how do they stack up against what we're already seeing from, say, the monoclonal antibodies, and then against each other?
Sure. So, whenever we talk about the effectiveness of these therapies or any therapies in general, it's just important to remember, first off, that none of these therapies have been directly compared to one another. So we can't say, with statistical certainty that drug A is better than the other. Another thing that we need to keep in mind is that over the past 2 years, I'm sure everyone's known, we've seen significant shifts in the pandemic landscape. We've seen different variants, different degrees of severity. So the timing of when a particular drug is being studied could really have a potential impact on its effectiveness. Now, with that being said, both of these agents, they were both studied during the same time period, as both whenever the Delta variant was predominant. And that, in my mind, is probably a good thing, because we know that the Delta variant was such a higher degree of severity variant. So the fact that these drugs were able to show effectiveness in the face of a more severe variant is actually kind of a notch in their belt. So all of the clinical trials of all of the different therapies, that includes these oral therapies, the monoclonal antibodies, they all measured pretty much the same thing, and that is how effective are these therapies at preventing death and or hospitalization due to COVID-19. So that's kind of the common measuring stick by which we can at least compare these drugs on a side-by-side sort of numerical basis. And when we look at that outcome, rates of hospitalization and or death was 88% lower with paxlovid compared to placebo. So putting that into some more real numbers, nearly 7% of patients in the placebo group experienced either hospitalization or death, compared to only 1% in the paxlovid group, which is a pretty robust reduction. And one thing that I'd like to add is that outcome that they were looking at, hospitalization or death. There's obviously a big discrepancy between hospitalization and death. In the paxlovid group, there were no deaths. So that is one of the positive things. The only outcome that the paxlovid patients experienced was hospitalization. So obviously, that 88% lower overall risk is great. And it actually stacks up well against the data that we saw with the monoclonal antibodies. And not to get into not to get into the weeds too much about the monoclonal antibodies, but during their trials, we typically saw risk lowering in the rates of 70s to mid 80s. So it's right on par with those. Now, the other oral drug, molnupiravir, unfortunately, it doesn't appear to be as effective. Now, again, we can't say that it's worse than paxlovid because they simply weren't studied directly against one another, but molnupiravir only reduced the risk of hospitalization and or death by 30%, which is a bit lower than what we saw with paxlovid. To put that into real numbers, nearly 10% of patients on placebo experienced the outcome, compared to nearly 7% of patients who took molnupiravir. So obviously you can tell the data just simply doesn't look as robust for molnupiravir. And I should kind of note as an aside that the difference in efficacy between these two drugs is likely the reason, or at least one of the reasons, why the FDA's authorization for molnupiravir states that it should only be used basically when other treatment options are not available. So there are currently 5 authorized for outpatient treatment. It is currently sitting at number 5.
I'm glad you added that context in, Chris, because, when you talk about those numbers, it's very easy to have a knee-jerk reaction when you see 88 versus 30%. And, it's very tempting to look at 30%. Why even bother? But at the same time, 30% is better than 0%.
Exactly. And just to note, to kind of put a bow on that, it's hard to say with it's hard to say definitively that one is better than the other because we don't know necessarily what happened in the clinical trial for molnupiravir. Perhaps it was the region of the country in which it was studied predominantly. There's a lot of factors because they weren't directly head-to-head studied against one another. You can't say definitively, but at least numerically you can look and see there might be something to it more than that, but we'll ultimately keep our fingers crossed for maybe some more robust studies in the future.
Definitely. Now, when you get a new drug out there, then the next question people tend to ask, what about the safety or the side effects? What concerns should I have in those areas?
Yeah, so I'll say upfront, the good thing about these drugs is that from a pure side effect perspective, is that they're both pretty well tolerated. The clinical trials didn't show too many things that were outstanding. Molnupiravir, actually, all of the side effects with molnupiravir were seen just as frequently with placebo, so there really was no difference from placebo in anything. One thing that I would note with paxlovid is they do see a higher incidence rate of diarrhea or like a metallic taste in the mouth that has been reported, but fortunately, the rates of those occurring are still fairly low. So overall, they're pretty well tolerated.
I do want to.
Go ahead.
Sorry, Chris. I wanted to ask real quick. When you say pure side effects, what exactly do you mean by that versus what you just talked about?
So essentially, I'm just kind of setting up a discussion of the side effects as opposed to theoretical concerns. As we'll be discussing shortly here, a pure side effect would be something that happens when you take the drug. So you have nausea, vomiting, diarrhea as a result of taking the drug. I kind of want to keep those separate from some sort of safety caveats that we'll be discussing, such as safety concerns with possible viral mutation induced by molnupiravir, drug interactions that you have to be concerned with for paxlovid. So when I say pure side effects, really I'm just talking about side effects and delineating them from other safety concerns.
Gotcha. Okay, thanks.
Yeah. So there are some other caveats that we should be mindful of with these medications. So first, neither of these drugs was studied in pregnant patients. So this is obviously going to be a limitation of these therapies. In fact, with molnupiravir, it's recommended that patients who may become pregnant use contraception for 4 days after their last dose of molnupiravir. An even longer recommendation is males who have a partner who could become pregnant. If they take molnupiravir, they should use contraceptive for at least 3 months after taking their last dose of molnupiravir. So obviously there's a lot of contraception consideration with regard to molnupiravir. Another concern, as I alluded to before, is with molnupiravir's mechanism of action. So because it works, like I said, kind of like a wrench in the gears, it works by inserting itself into the virus's RNA. There's at least a theoretical concern regarding the long-term potential for this drug to induce mutations in the virus. Now, so far, this hasn't occurred, and there's no way of saying that even if it did induce any sort of mutation, that they would be significant enough to merit any real concern. But nonetheless, it's still something that the scientific community has been aware of and will be no doubtedly looking at for some time to come. And finally, there's also the concern, like I said before, of paxlovid and drug interactions. So remember back a couple minutes ago where we were talking about how paxlovid contains ritonavir, which can increase the levels of certain drugs. So it shouldn't be used in patients taking certain medications. Now, this list is somewhat extensive, so I'm just going to direct our listeners to see the full list in the prescribing information. But there are some fairly common drugs on the list, I would say most notably being Simvastatin and Lovastatin. I would just also note that those are the only 2 statins that are listed. The other statins would not be an absolute contraindication. It would just be more of what we consider something to monitor closely. But for providers or just anyone who's curious about screening for drug interactions with these medications, I would actually highly recommend the online COVID-19 drug interaction checker. It's produced by the University of Liverpool, and it's a very nice resource to use if you have any concerns. So we can put a link to that in the show notes. I'm sure, right, Adam?
Yeah, oh yeah, definitely we can do that. We also put the FDA fact sheets for both of these therapies up there as well. 100% we can do that, and we will do that. Talking about the safety concerns and side effect concerns, just an interesting thing I saw when researching these two therapies, before our show, just an interesting thing about molnupiravir. I saw that, it's indicated for people 18 and older because it might affect bone and cartilage development in younger people. And I just found that fascinating.
Yeah, and there's been some controversial studies that they saw in animal studies, and to what you mentioned, a lot of the bone and cartilage development. And that's actually one of the reasons why, as I was actually going to mention a little bit later, the emergency use authorizations are slightly different for these two drugs. So paxlovid is authorized for 12 years of age and older. Molnupiravir is more restrictive. So it's only 18, or, adults 18 and older. So with molnupiravir, not only do you have the EUA stating, hey, use this more as like a last resort kind of thing, but you also say you have a more limited patient population in which you can use this drug. So while I don't, from a clinician standpoint, I do try to not play favorites so much, but I would say that paxlovid does seem to be the more widely used one right now.
Remember the Diamond Drug Information Center? That group of expert pharmacists who help Diamond customers with their medication questions? Well, I'm here to tell you that they're a thing of the past, but not in a bad way. No. The Drug Info Center has a new name and a new mission. We're proud to introduce the Office of Pharmacy Therapeutics and Integrated Clinical Services, or OPTICS. Instead of offering just drug information, the pharmacists of OPTICS are moving their services closer to direct patient care. Whether it's through collaborative formulary management, medication therapy management, or individual patient care plans, the OPTICS team is ready to integrate their clinical pharmacy expertise into the day-to-day operations of medical teams in corrections and long-term care, and they'll continue to offer the same drug information resources they've provided in the past. To get a clearer view of OPTICS and its mission, go to diamondpharmacy.com/OPTICS team to learn more. Now back to PodcastRx.
And when we're talking about wide use, just in general with both paxlovid or molnupiravir, how accessible are they at the moment for the general population?
Yeah, so unfortunately, the drugs are still in short supply. I guess that, being new to the market, it shouldn't really be any surprise. But not every, and not every retail pharmacy has access to these drugs. So it may vary depending on your location. Now, with that said, at the time that we're recording, there are actually 6,370 pharmacies located across the United States with access to either one or both of these drugs. That actually makes for a total of roughly, I believe the total was 300,000 courses of medication available. Currently, there is more molnupiravir available than paxlovid. It's almost a 2-to-1 ratio. And this might sound 300,000 courses, that might sound like a nice supply, but when you consider the fact that the current 7-day rolling average of new cases is about 130,000 per day in the US, you can start to understand why this might not be enough, at least in the long run. So obviously we're hoping to see availability continue to increase. And one thing that is nice is there is a COVID-19 Therapeutics locator that was put together. And again, we can put that link on the website as well. It's not necessarily for, there's a big banner right at the top. It says not for, patient use, don't call the pharmacies and whatnot. That's probably just from like an overload. You don't want to overload the pharmacies, calling them to see if they have it type perspective, but it is helpful for providers. It allows the providers to see, hey, which pharmacy in my area or around my patient's home has these therapies available.
Yeah, you definitely don't want to overwhelm the pharmacies for sure. An interesting thing that you talked about was the disparity between how much molnupiravir is available versus paxlovid, and I assume molnupiravir is the number 5, down the list treatment, and also paxlovid is 2 drugs in one essentially. So might that account for the disparity, those 2 factors?
Yeah, I do think that that's probably it. I do think that it's because whenever you look at the treatment guidelines right now, you're seeing Paxlovid as being the number 1 recommended therapy, and that's obviously going to be driving Paxlovid utilization. But to be fair, when they both came out, I think Monoperovir just came to market with a greater supply than Paxlovid did, because even when I first looked at this back in right at the beginning, at the end of December, Monoperovir had more doses available. I think it was still a 2-to-1 ratio at that time too. So it might just be more of like a supply rather than a provider choice driven situation, but it could be both.
Understood. So from your understanding, and again, we've been talking largely about the application of these out in the wider world, but your expertise comes especially in the institutional framework, corrections and long-term care facilities. So from your understanding, how widely are these being prescribed?
Yeah. So overall, I would say that the uptake has been somewhat surprisingly low. But again, that's based on my own perspective. And I'll caveat that basically with what you said, is that my perspective is heavily influenced by the institutional sector. And obviously, for those, the correction, nursing homes, the logistics can be somewhat of a larger hurdle than what you would see in the community. Now, with regard to the community, or the quote unquote outside world, as I like to call it, so my wife is a provider, so I'm very fortunate to get her perspective on not just this, but on all things as well. And I know that she's personally been utilizing these agents basically since their authorization back at the end of December. And just anecdotally, she's successfully ordered these for probably 5 to 10 patients. That obviously sounds somewhat low, but you also have to take into account too that there's still a lot of hesitancy with these medications, and that's going to vary based on your geographic location. So obviously, the patients who decline to use them are keeping those numbers low as well.
I would assume that because these are investigational therapies under the emergency use authorization, that you're going to see a lot of the same wariness that greeted the vaccines as well.
Yeah. And even just speaking anecdotally, I've known many people who were also not as apt to take the monoclonal antibodies either. And we know the monoclonal antibodies were basically one of the most benign therapies that you could use. So it really does, just because we have therapies available doesn't mean everyone's going to use them. I mean, not everyone used Tamiflu for influenza as well. So
yeah,
you're always going to see less demand than peak, so to say.
Right. Well, and I think another important point to reiterate is that both therapies, they're reserved for patients with a risk of progression to severe COVID illness or hospitalization. So even if supply wasn't an issue, even if hesitancy wasn't an issue, it's not like you would be seeing anybody with a positive COVID test just getting a prescription for either of these.
Correct. Yeah. So these are definitely still reserved for those high-risk patients. So it is a bit more of a limited population in and of itself. Although, just as an aside, a lot of people could fall into the high risk category when you consider even the fact that hypertension could qualify a patient for this. So there's still a decent enough population size to use these therapies if they're needed.
Going back to your institutional framework that a lot of your experience is based on with these, what's it been like as a member of Optics to deal with these antivirals? Are you getting a lot of questions about them?
Yeah, so mainly what I've been doing is providing a lot of education on these therapies, and really that has involved some proactive measures. I'll compile write-ups. Me and my colleagues will compile write-ups as the drugs become available. We'll include summaries of the data, the dosing, basically everything that our facilities and providers would want or need to become familiar with these medications prior to using these medications. But also what I've been doing, what we do in Optics is we answer questions, right? So this is much the same. We answer questions as they arise from the facilities and the providers. And I would say that most notably, a lot of the questions so far have simply been in regard to like logistics, as in how do we obtain the product. And I would say that it's important to highlight the fact that while we were discussing, patients in the community, they can go out to their select local pharmacy. They can just get it, pretty locally there. We've been directing our correctional facilities and nursing homes, the institutions to contact their local health department, because at least as of right now, these unique environments kind of have their own unique method of obtaining these therapies. So with Optics in our day-to-day, I would say logistics has been a fairly prevalent concern.
And of course, supply chain issues, that's the way of the world right now, having to navigate those in pretty much any area of our lives. And, it's not at all, not at all a surprise that we would have the same issues with these new therapies. Going back to the drugs themselves, what are some important caveats, aside from the safety concerns and side effects that we talked about earlier? What are just some caveats people should understand when looking at these drugs overall?
Well, first and foremost would probably be the timing of treatment. We haven't mentioned that yet, but probably many people, many listeners are familiar with Tamiflu for influenza. Remember how it was recommended to use it within 48 hours of the start of symptoms? Well, these agents are pretty much similar in the fact that it's time sensitive. So it's recommended to start treatment with either molnupiravir or paxlovid within 5 days of symptom onset. And now when you compare that, to the 48-hour rule with Tamiflu, 5 days is a pretty gracious window. But I will add, it's still not as gracious as the window that you see with the monoclonal antibodies. So the two that are currently available right now, bebtelovimab is a 7-day window, and sotrovimab is a 10-day window. So that's probably one of the most important things to consider. Another thing to consider is that paxlovid requires dosing adjustments in patients with impaired kidney function. And the interesting thing about this situation is how paxlovid is supplied. So remember, paxlovid is a combination of two drugs, nirmatrelvir and ritonavir. But unlike traditional combination medications, which typically come together in a single tablet, this product comes as nirmatrelvir and ritonavir as separate tablets. So paxlovid actually comes in a package with 20 nirmatrelvir tablets and 10 ritonavir tablets. Now, a patient with normal kidney function will take 2 of the nirmatrelvir tablets and 1 of the ritonavir tablets in the morning and again in the evening for 5 days. Patients with impaired kidney function, however, will only take 1 nirmatrelvir tablet and 1 ritonavir tablet twice a day for 5 days. So that has kind of put pharmacists in this interesting situation of having to punch out 10 nirmatrelvir tablets from the package and essentially throw them away prior to dispensing this medication to patients with impaired renal function. Now, I'm hoping that Pfizer just did it this way in an effort, to try and rush to get this drug to market as soon as possible. Obviously, I can't assume, but I'm hoping that's the case, because I'm also hoping that in the future it will just become a single tablet that you take twice daily, almost like a Z-Pack situation, and that they'll also produce a lower strength tablet for those with kidney issues. It would just make life, again, logistics, it would just make life a lot easier from a logistics standpoint.
Yeah, no doubt.
Yes. So, and I know that's thrown everyone through a loop, in the pharmacy world, those who are actually, dispensing the product. Now, I should note though, in that same vein, that molnupiravir, one of the benefits of molnupiravir, does not require dosing adjustments based on kidney function. So the dose of molnupiravir is 800 milligrams twice a day for 5 days. But molnupiravir is only available as 200 milligram capsules. So patients will have to take 4 capsules twice a day for 5 days. So essentially it comes, in a package of 40 capsules. But the good thing about these products is that they come in individual packages that are basically 5-day packages. So you just take all the tablets that are in there. And one final caveat with these drugs, and this is not intended in any way to dissuade anybody, but I think it's important to mention, even if only from an academic exercise, is that these oral drugs weren't studied in a vaccinated population. And remember, one of the biggest benefits of vaccines is that they reduce the severity of COVID-19 cases. So basically both things, the oral drug and the vaccine, are doing the same thing. They're reducing the severity. So we don't know yet how much extra benefit that these oral drugs would give to a patient who have already been vaccinated. Now, obviously, with that said, I would still and have still recommended these for vaccinated patients. I think that it never hurts to have too much treatment in this case. So, but I think that's just an interesting thing to note.
Yeah, and I think in that last point you made, that you kind of buried the lead a little, but the message remains, get vaccinated.
Yes, absolutely. That at the end of the day, that is the number one tool in our toolkit for this.
Yeah. Well, I've got one final question here, Chris, and it just as we like to tie up a lot of these episodes, just kind of about your thoughts on the future, and how do you think the development of these oral therapies like paxlovid, like monoperovir, will proceed moving forward? Are we going to see a lot more of these springing up in the next year or so, do you think?
Yeah, I mean, ultimately, I believe that oral therapies are going to continue to grow, in their overall utilization. And that's because, like what I mentioned before, it's because you have the ability with oral therapies to reach a much larger patient population. And to this point, we know that there are others. There are other oral agents in later stages of clinical trials, which is great. But it's hard to get our hopes up at this stage, simply because, as we all know, how many other drugs, have we seen over the past 2 years be tried and failed in clinical trials? But I think what's important to highlight with that is that most of those drugs studied in the past, they weren't really COVID-specific drugs. We're at a point now, though, where most of the drugs in clinical trials that are they're being created with COVID in mind. And I think that's where treatment is headed, designing oral drugs that are more COVID specific and drugs that work on a more universal mechanism, a universal mechanism that isn't going to be so susceptible to change, which ultimately means that these new drugs would be essentially immune to viral mutations. And that's ultimately going to be the important point here. Immunity to viral mutations, because we're already starting to see some of our therapies lose their effectiveness with changes in the virus. So, for example, just recently, once the Omicron variant became the dominant variant, we lost 2 of the most widely used monoclonal antibodies, those being bamlanivimab, etesevimab, combination, and casirivimab and imdevimab combo, the latter often going by the name Reg and Cove. Fortunately, sotrovimab maintained its effectiveness, but that's because it targeted an area of the spike protein that wasn't really prone to change. Again, so by targeting things that aren't as susceptible to change, like the protease in the case of paxlovid, viruses don't tend to change their proteases. Not only are we creating more accessible treatments by making them oral, but we're also creating more durable treatments in the long run. So I think that's kind of where the overall clinical environment is going to shift to. I do think the infusion monoclonal antibodies will be around for quite some time as well. But I ultimately see those as being a bridge until we have these, a much broader arsenal of oral therapies available at our disposal.
A broader armamentarium.
Exactly. To bring it full circle.
Well, whatever those down the line treatments will look like, I'm very certain that we're going to have you back on this show to tell us about them. Chris Bender, thank you so much once again for joining us here on PodcastRx.
Well, again, thank you for having me. The day that those come to market, I will be happy to join you again, Adam.
Excellent. All right. We'll talk soon.
All right. Take care.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.